Thank you, Peter. And let me add my thank you to everyone joining us today and tomorrow. Thank you especially to those who are helping to get the message out about the challenges to our mental health during this unimaginable pandemic, and to those who have joined actively in all range of peaceful engagement and activity against the bigotry and racism that have undermined our mental health during these horribly troubling times. As Peter said, I'm Paul Gionfriddo, President and CEO of Mental Health America. Let's start by being clear. The pandemic isn't just about the challenges to our physical health and well-being, because hundreds of thousands of people have been experiencing serious mental health symptoms since the start of the pandemic too. Since February, MHA has been using its online mental health screening program, www.mhascreening.org, to track the real-time impact of the pandemic on mental health conditions. More than 1 million people have come to MHA to take a mental health screening since the start of the pandemic. The largest numbers have come this summer. Our program has now reached nearly 6 million people with tools and resources to learn more about their mental health conditions and improve or maintain their mental health, and more than 1 million since the start of the pandemic. And it has given us some amazing real-time insights into the population that we have gotten to share nationally and internationally through media outlets including CNN, MSNBC, ABC, NBC, BBC, Al Jazeera, NPR, and the Washington Post, just to name a few. But here's one bottom line. Collectively, between the end of February and the end of July, more than 263,000 people, over and above what we would have expected, screened moderate to severe for depression or anxiety. Screening respondents cite loneliness and isolation, relationship problems, current events, and increasingly financial problems as reasons for their mental health conditions at the present time. And as we approach 200,000 deaths from COVID-19, a quarter of our screeners are also experiencing grief. Young people continue to be disproportionately affected by both anxiety and depression, but different populations are all affected and cite some differing reasons for their concerns. And in something that we believe has been underreported, other severe mental health conditions, in addition to anxiety and depression, also appear to be on the rise. For example, more than 42,000 people have also now experienced symptoms related to emerging psychosis. And most worrisome to us are the more than 100,000 people, as of today, who have reported regularly thinking of suicide or self-harm. There is no doubt that we are in a mental health crisis, and we can't ignore it lest this become a mental health catastrophe. So we're starting this conference off by talking about it, talking about COVID-19, isolation, depression, anxiety, all of it. And our first guest knows the realities of these numbers more than most. Dr. Joshua Gordon is the director of the National Institute of Mental Health. NIMH is the lead federal agency for research on mental disorders. NIMH is one of the 27 institutes and centers that make up the National Institutes of Health, the largest biomedical research agency in the world. NIH is part of the U.S. Department of Health and Human Services. Josh became the director of the National Institute of Mental Health in 2016, and he oversees an extensive research portfolio of basic and clinical research that seeks to transform the understanding and treatment of mental illnesses, paving the way for prevention, recovery, and cure. He is also leading, with my friend Patrick Kennedy, a public-private partnership in which MHA and others are participating, for the National Alliance for Suicide Prevention, aimed at building a mental health recovery plan for the present pandemic and future health and environmental challenges. Welcome, Josh.
Thanks for having me, Paul, and it's a real pleasure to address the members of the MHA and others through this virtual conference.
We're so glad to have you here. You know, the work that you're doing is so important, and really during your tenure at NIMH, you have really reached out, I think, in partnership and collaboration with so many organizations like ours. It's making a huge difference. It's helping us all come together as well.
We recognize we can't do this alone from a research perspective or from any other perspective. We need the help of everyone we can get to achieve the goals that we share.
So you've heard my kind of 3 minutes of what I've been seeing, what we've been seeing over the course of the last 6 months. Care to share some of your impressions about what you've been seeing and whether this is different or the same as what you were seeing before?
It's clearly different from what we were seeing 6 months ago. That said, it is consistent with what we've seen in the context of other disasters and epidemics in the past. We're finding that somewhere between 2 and 3 times as many people are reporting symptoms of depression, anxiety, grief, stress, and worry than would be under quote unquote normal circumstances. So, as we might expect, we're seeing a great increase in mental health related symptoms. We're also hearing from our mental health care providers that we're seeing increased demand and utilization of those services. And what's really interesting about this particular pandemic is that there's been an explosion in the use of telehealth and other technologies to deliver mental health care, which, of course, has been really important given the necessity for social distancing that's been occurring to mitigate the effects of the pandemic itself.
Yeah, that is one of an interesting thing, and I know we're going to have an opportunity over the course of the next couple days to talk more about the changes in telehealth opportunity that's been there. I mean, if there's one good thing coming out of this, it's the increased and improved access to a variety of behavioral health services because we have telehealth available to us now.
Yeah, that's 100% correct. The increase in availability, the increased awareness, the increased degree to which both providers and clients are becoming comfortable with these approaches is a silver lining. There's another silver lining, if we can even call it that, to the pandemic, and that is the kind of conversation that we're having right now is actually happening throughout many different areas of our society. There is a recognition that the mental health impacts of this pandemic are going to be significant. There's the recognition that we don't have adequate access to mental health care in many parts of our society. And we can hope that we can use this increased recognition and build momentum towards an improved mental health care system in the United States.
Yeah, it's really different from the way it was when I just think back to March. Initially, it was all, physical health impact all the time. And I remember we were first asked the question about anxiety by a news media person back in the first week in March. And so we started looking because, as you know, we can look real time at our data from help seeking people and began to see that increase right then. But it really seemed to take off both attention to this and the mental health aspects on about a 6 to 10 week lag after people began to experience the effects of the pandemic. Would that typically be the case that we're just a little behind where people are in terms of their acknowledgement and recognition of the physical side of this?
I think well, first of all, the delay is consistent with what we've seen with other emergencies. Whether it's to do with the recognition or rather the other aspects of what's going on is unclear. What do I mean by other aspects? I mean that in the case of threats to one's immediate safety, one's health, one's safety, the ability to get food and shelter. These are the first primary needs that we all have as individuals. Once we've secured those basic elements of safety, then we are concerned for more chronic issues, and mental health is absolutely one of them. So, in the early days of the pandemic, I think most of us were concerned with making sure that we weren't going to become ill from the virus or making sure that our loved ones had what they needed to be able to live day to day. And once those needs were at least attempted to be taken care of or mostly resolved, that's when we started recognizing that, wait a second, now I recognize I'm incredibly depressed or I'm feeling really anxious for the future, and those needs come to the fore.
Yeah, that seems to be sort of a common experience. And I know that we've seen so many more people who are screening with moderate to severe anxiety that what happens is they initially experience, and in the case of trauma too, you initially experience the event, and it's once the event seems to abate or the immediate physical impact of the event seems to abate, that's when the feelings of the anxiety or the post-traumatic stress or even the depression really begin to take root and emerge. And I know you've built the case, and as we have, for trying to recognize that early on so that you can intervene early on, because it does make a difference, doesn't it? I mean, waiting too long is going to lead to more catastrophic effects.
That's correct. What we want people to do is be able to recognize the early stages of anxiety, depression, post traumatic stress, and get help in one way, shape, or form. The earliest symptoms are often best dealt with through typical coping mechanisms: getting enough sleep, enough exercise, enough food, and healthy foods, avoiding drinking and avoiding drugs. The other coping mechanisms that have been particularly important with this pandemic is ensuring that you maintain active social contacts. I still like to say, but I said it a lot in the early days, that social distancing shouldn't be called social distance. It should be called physical distancing, and we should remain socially connected. And there's lots of tools for doing that. And I think, fortunately, people have really taken advantage of that. If those coping mechanisms fail and people start to become overwhelmed by their symptoms, that's when it's important to reach out. And the earlier one reaches out to friends, family, uh, uh, pastors, religious leaders, counselors, therapists, psychiatrists, the earlier one reaches out for help, the more effective that help can be at preventing the worst consequences of mental illness.
Threaded throughout the next couple of days, we'll be talking about some of those coping tools and mechanisms and strategies that people can use for themselves, and also some of the supports that are out there for people to make use of. I was wondering though, in kind of in addition to that, one of the things that I was asked about early on, and I'm a non-clinician, so when they said to me, well, what else should people do, if they're to deal with these worries that they were having. And I would say, don't guess, take a mental health screen, and you can use the basis of the results of the mental health screen to go talk with somebody, talk with a professional, clinician, a family member, and others. Would that be your advice too? You're the clinician here in the room, so I don't want to
Yeah,
go against what clinical advice would be, but if those coping strategies aren't working, is it a good idea to just go, take a pressure check on stress, just like we take a blood pressure check, and work from there? Or should people guess?
I don't think people should guess. I would myself err on the side of reaching out for help, but most people uh, need some help in sort of trying to figure out if the level of distress that they're experiencing is truly problematic and worthy of more attention. And screeners like what you have on the MHA website can be really really helpful for people to see, well, I'm experiencing something that's maybe beyond what I might expect at this point in time, and may be causing me enough dysfunction, enough harm that it's worth reaching out. There are lots of other ways to do it, but I think when you use a screener that has evidence behind it, when you can use these things to sort of quantify the level of distress that you're experiencing, it can have two effects. One, it can raise your alarm in case enough to seek out the professional help that you need, and two, it can provide some reassurance that what you're experiencing is not you're not alone. There's lots of other people who've experienced it enough that it can be described and written down, and that can be reassuring to people as well.
Yeah, and of course that's what our data have shown us. The million, millions of people, 6 million in the course of 6 years, but a million since the pandemic, who have screened, are certainly not alone. There's millions of others who are feeling what they're feeling, and I agree. I think that we've seen that the ability to learn about this and just surface it and then be able to talk about it often encourages other people to learn about these signs and to surface them, and also to seek and to give help. And I just want to mention on the side, because many people may not know who are seeing this and us for the first time, Mental Health America, because we have many thousands of people who are participating here, more than we would typically have at an annual conference. The screening tools we use are not screening tools that we made up or we invented. They are for depression, anxiety, and other conditions among the most common tools used in clinical settings to screen for depression and anxiety. And as you said, they are all evidence-based. So I did want people to know that, we're not telling people to do something that's proprietary to MHA or, taking a screen. We're trying to make available to people the same kinds of tools that clinicians might use, so that if they do get results and they do want to follow up and get help, they've got a language and a vocabulary to talk to either their primary care doc or specialist or somebody about what they're going through.
That's a good point, Paul, and I've certainly used some of those same screeners in my own practice when I was seeing patients myself. One of the other benefits of using these tools is that people may not recognize that some of the things that they're experiencing are even due to their mental, to their emotional symptoms. People may not recognize that decreased appetite or decreased sleep are actually symptoms that are related to their anxiety or their depression. They may not realize that the reason why they've been avoiding people or having trouble doing the crossword, which they used to love, might be related to these emotional symptoms. So these screeners can be helpful in that way as well.
Yeah, and that's really important because, again, over the course of this pandemic, we've certainly gotten a lot of anecdotal responses back from people about sleep being disrupted and certainly eating habits being disrupted. And so it is important, I think, for people to draw the connection and to know that there is potentially a connection and then an answer. One of the questions in the depression screening tool that we use is what we'll call the suicidal ideation, suicidal or self-harm thinking question. And it's one of the 9 in the depression screening tool. And one of the things that we have seen, as I mentioned in the opening, is just an astonishing number of people, and it skews young, who are reporting thoughts of suicide or self-harm on nearly every day, either every day of the week or on more than half the days. And in July, for example, just as 1 month that comes off the top of my head, 17,000 screeners said nearly every day, and 30,000 said at least on more than half the days. I mentioned in the opening in introducing you that the Action Alliance on Suicide Prevention has put together a group that you and Patrick Kennedy are co-chairing, that I've been participating in, that really is aimed at not just broad scale preventive work in the light of the pandemic and as a result of it, but also with a particular eye toward suicide prevention. Could you talk a little about that work and what you're bringing to it, and how you see us getting a handle on these numbers of people, particularly young people, who are thinking about suicide or self-harm on a daily basis, and what it is we can offer to them for hope?
Yeah, so thanks for the opportunity to talk about that. The National Action Alliance for Suicide Prevention is a public-private partnership and involves multiple federal agencies as well as all, all different individuals from the private sector, including some companies, big industrial companies, insurance companies, hospitals, as well as self-advocacy organizations and other nonprofits that are in the mental health space. And its primary overarching goal is to try to stem the rising tide of suicide. As you know, and as I'm sure most of your members know, suicide was an epidemic before the pandemic came along, and it remains a huge concern. And of course, it's probably the worst outcome of mental illness that we can imagine. And unfortunately, as I said, it's on the rise. The recognition that the coronavirus pandemic might add to the many causes of this increase in suicides in the United States led to the desire to form a subgroup of the Action Alliance that's focused on a national response to the mental health needs of the pandemic. And this national response group, co-chaired by myself and former Representative Patrick Kennedy, a huge advocate for mental health services and mental health equity, has been formulating a number of principles that we want to advocate for that are focused on suicide prevention and on the mental health consequences of the pandemic. Some of the things that we're working towards is ensuring that all our partners know evidence-based practices moving forward that with which the burdens of these dual pandemics, the suicide epidemic and the COVID pandemic, what resources we can bring to bear that already have an evidence base, uh, making sure that the expansion that we mentioned earlier in telemental health is able to be continued as the pandemic drags on as an important tool for increasing access to mental health care, and ensuring that providers who are responding to the pandemic appropriately by delivering mental health care are using evidence-based practices. So these are some of the things that we are active in. What's nice about the group is that NIMH can bring the expertise in terms of the research results, what findings we know that are important to think of as we formulate these recommendations, and the healthcare organizations can bring that information and back to their constituents. The companies can bring it back to their HR divisions to demand appropriate mental health care from their health insurers, and the advocacy organizations can work with members of Congress and with other important influencers to push this agenda forward. So it's really a wonderful public-private partnership.
Yeah, and one of the things that I've really appreciated is the breadth of activity and thinking that's on there, but in fact the consistency of approach in moving us. I think for a lot of people, moving us further upstream. I have a special interest in kids and kids' mental health and in prevention and early identification and intervention. And I think that everybody, even those who are primarily late stage interveners, have figured out here, and maybe again another one of those silver linings of the pandemic is people have been figuring out that we're facing the earlier stages of mental health conditions. We're kind of seeing them emerge in ourselves and our neighbors. As we said, even in psychosis, we're seeing this remarkable increase in the number of people experiencing symptoms of psychosis. And so everybody, I think, is kind of giving fairly weighted attention now to the earlier stages. And I know that's been a big push from NIMH, for the last several years. So are you happy about that?
As much as one can be happy about any developments that are happening in the context of the COVID pandemic, the recognition that mental illnesses begin, for the most part, in childhood or at the latest, early adulthood. And that understanding what's going on in those early stages is really crucial, not just to develop new treatments, but also to think about how we might prevent the onset of the worst aspects of mental illnesses. We've been expanding our research programs in that area. It's an area of great interest, but we can only succeed if people are aware that, when things are going a little bit awry, then maybe it's the time to get some help, because then we can again try to intervene earlier, and have greater success. The research that we've been conducting so far does suggest for many illnesses, including schizophrenia and autism, but also depression and bipolar disorder, that the earlier one intervenes, the more effective and the better that we can be at preventing loss of function in life, and ensuring that people maximize their potential throughout the rest of their lives.
So, I subscribe to the notion, of never asking a question where you don't have an idea about what the answer is going to be. But in this instance, I genuinely don't know what your reaction is going to be to this. And I'm really curious because I do want to ask you about the psychosis numbers that we're seeing. And what do you make of that? Do you think this is maybe just an anomaly of some kind, or just that there's greater attention? Or do you think it's possible that it's not just anxiety, depression, post-traumatic stress, or the likely things that we would see in response to a pandemic and the social unrest that we've seen subsequent to that? Do you think, that again, these environmental factors could be contributing to earlier onset or additional onset of conditions like psychosis?
So there's a few aspects to the answer to that question, and I'm really glad you posed, Paul, because it gets into some of the misconceptions around psychosis per se. Uh, so schizophrenia, which is a fairly debilitating disease, and it is what we normally think of when we think of psychosis. This is a disease that strikes typically in late adolescence or early adulthood. It results in a number of symptoms, including psychotic symptoms like hallucinations and delusions, but also cognitive disruption and social dysfunction. Schizophrenia is, we think of as less environmental. That's not really true. There are environmental components to schizophrenia, and maybe are surprised if the rates of psychosis go up in that context. But one has to remember that psychosis is a feature of bipolar disorder. It's a feature of depression, and it's a feature of actually even normal life when people get stressed. So that could be one thing that you're seeing, is that people are noting psychosis symptoms because they have these other disorders, which we tend to think of, right or wrong, as more related to the environment. The second thing that I would say is that even individuals with a pre-existing psychosis or a predisposition to psychosis are more likely to experience psychotic symptoms in the context of stresses. And we have numerous stresses going on right now. We have the pandemic, we have isolation, we have the economic implications, we have the racial strife, the strife around racial discrimination that is going on in this country. We have a lot of different reasons for people to be stressed right now. And so that's going to increase the rate of psychotic symptoms, whether those symptoms are occurring in individuals with schizophrenia, with depression, or with more milder forms of mental illness. So I think all those would suggest that it's possible that actually the rates of psychotic symptoms are increasing in society right now. The It's also possible that what you're seeing is just an increase in the reporting. We were just talking about how people are more attuned to or becoming more accepting of mental illnesses as a consequence of this pandemic, and we might be seeing an increase in reporting. I think, though, that it's likely that stress is increasing the rates of psychotic symptoms in the population, at least modestly, and that is probably contributing to it. What will be interesting to see, and what I'm a little bit more hopeful about than the numbers might suggest, is whether this abates and reduces as the pandemic is resolved. And that might take a while, but we do hope there'll be a vaccine. We do hope that people will be able to get back to work and school without worry, sometime in the not so distant future. And what we've learned from prior pandemics, and well, not so much pandemics, there's not really a prior one for a while, but previous epidemics and natural disasters, is that only a small minority of the people who experience mental illness in the context of the disaster will continue to experience that a year later. So there is actually an increase in the rate of mental illnesses in the wake of disasters, but the increase is more modest than the numbers might suggest when you're in the heart of the disaster. So we can hope that this increase in psychotic symptoms that we may be seeing right now will at least partially resolve as the pandemic abates.
Our time is drawing to a close here, but I wanted to get in just one additional question. Again, and over the course of the next couple of days, we'll be, weaving in both the themes of the pandemic specifically, and then, the social unrest, frankly, that we've been experiencing too, and all the effects that that's had on us. And certainly one of the things that we're seeing in this context is that, different populations, different groups, racial and ethnic groups, seem to be experiencing the pandemic differently, and obviously experiencing the world and the country differently right now. Any guidance or advice from the perspective of a behavioral health professional, probably the lead professional in the country, about ways we should be thinking even today about working through these things and understanding and addressing the differences that different population groups may be experiencing these days?
Well, I think first is recognizing that what is happening, both in terms of the unrest and racial discrimination, and in terms of the pandemic, is adversely affecting minority communities even much more so than the rest of society. The rates of infection with COVID are much higher in African American communities, in Hispanic communities, and Native American communities, and it's these same communities that have faced the other pandemic of discrimination, of police brutality, and of in unequal access to all kinds of resources, including healthcare and mental health care resources for decades, for hundreds of years. That means that the impact of the pandemic is not only going to be more strongly felt in those communities from a physical health perspective, but also from a mental health perspective. That also means that we need to devote resources. From my own perspective, I'm talking about research resources, but from the general societal perspective, we should also be thinking about resources for physical and mental health, economic resources, et cetera, into these communities to help buffer against what's going on. So that's what we need to do. We need to think uh, importantly about how our own organizations can work towards more equity in this space. From my perspective at the NIMH, it means that we are investing in research programs in these communities, both related to COVID and related to mental health disparities that exist. I'd imagine from organizations like yours that you are listening to your members in those communities and trying to make sure that the resources that you put in place are reaching members in minority communities. There is lots of reason to be hopeful. Minority communities have especially strong social networks, particularly in relation to churches and community centers, but in lots of other ways. And harnessing those social connections to help shore up the mental health of individuals in these communities is something that we're working hard at, and that could have some real benefit as we work our way through these many different forms of stress and strife.
Well, thank you for this, Josh. Thank you for the important conversation, for all the work that you're doing at NIMH. I know we're going to continue to work together to tackle these tough issues, and that we will bend the curve of these numbers. And we'll do it today, before emerging conditions become, as I say, stage 4 crises. So before stage 4. So again, thank you for joining us, and thank you for all you're doing. If people don't know, you're the Anthony Fauci of the mental health side of NIH. So just wanted to share that with everybody.
There's no Tony but Tony, but I appreciate it. I appreciate the invitation to talk here. Appreciate the opportunity to think about these things with you. And I really appreciate all of your members who are striving every day to make things better for the community of individuals who suffer from mental illnesses, and who really advocate on the behalf of everyone, but also on the behalf of NIMH and the research that we do. We really do appreciate your work.
Thank you very much. We'll take a quick break now and be back with former South Carolina legislator and now CNN contributor Bakari Sellers. Stay tuned.